Tonight, we have Dr. Legenia Bailey, who's going to be talking to us about TAAR1, and I'll do a little bit more of an introduction for her when we officially get started. But first, we do have a sponsor for tonight. So we've got Rich Stagnato with us from PRMS, so he's going to speak briefly before I introduce Dr. Bailey. Rich?
Hi, thank you, everyone. It's great to see everyone, and I want to say Happy Doctor's Day to all the doctors out there. We just want to say kudos. It's from a non-doctor. I just want to say it is appreciated for all the hard work you do. We do put a little blog about it on our website, prms.com. So if you feel like it after the meeting, feel free to check it out. We're happy to be a silver sponsor of the Illinois Psychiatric Society. We've been for quite some time. And one of the ways we try to support the society is we have a referral program. For those who don't know, PRMS manages medical malpractice, insurance, and risk management services to our policyholders. So if you know any colleagues who are in the market for insurance coverage, you refer them to us. And they name you as refer. You will let us know where you want a donation to go to for you. So it could go to the Illinois Psych Society, for example, whether or not the referred person buys a malpractice policy. A couple things we're just going to plug for anyone who's going to the APA annual meeting. We're going to be out there as well. We have a risk management course out there that's complimentary for our policyholders. And of course, if you're looking for something to do, because there's nothing else to do out in San Francisco, we are having reception out there as well. So feel free to look out for any invites if you haven't received one already from us. And for any colleagues who are graduating this summer, we do have early career discounts for our new psychiatrists up to 80%, part-time discounts. I won't bore you with all the details. It's all on our website for those who want to check it out. So I just wanted to thank you for the opportunity to be here. And I think it's a cool topic. I think you'll have a great meeting and spirited discussion.
Thank you for coming.
Yeah, thank you, Rich. Thank you to you and to PRMS for being sponsors. All right, so now I get to introduce our speaker for the evening. We are very honored to have Dr. Legenia Bailey, who holds a doctorate in pharmacy and is board certified in psychiatric pharmacy. She is the director, medical science liaison, and national lead for patient centricity and engagement for the medical science affairs in psychiatry at Synovian Pharmaceuticals. She's been on development teams for 3 different antipsychotics. She has worked as a clinician, researcher, and advocate, got her doctorate in pharmacy from the University of Illinois, completed a residency and fellowship in psychopharm at UMKC and Greater Kansas City Research Foundation. She is also hugely involved in NAMI. She's been involved with them for 35 years. She has personal lived experience of family members with mental illness. She's also served on the national boards of directors for the Depression and Bipolar Support Alliance and This Is My Brave. And then on top of all of that, she's also a yoga therapist and has taught yoga and meditation practices for over 20 years across the entire planet. So she brings a wide breadth of knowledge and experience, and she's going to be talking to us about TAAR1, what it is and how it may affect our clinical practice in the future. She will be talking about some investigational products, but she won't be able to answer specific questions about those products during this session because of the phase of development that they're at. So if you have questions, she can answer those one-on-one after the session's over. She's going to provide us with her email. So if you have a specific question about one of the investigational products, feel free to email her after this. As she's speaking, also feel free to drop questions in the chat. I'll be keeping an eye on the chat so that we can roll right into the questions once we get to the Q&A portion. And I believe that's it. Kristen, did I miss anything? All right. So Dr. Bailey, thank you very much.
All right. Thank you so much, Dr. Houston, for that lovely introduction. And I'll live up to my bio in this talk. So I'm going to start sharing my slides and just give a minute for those to load. And we'll start from the beginning. So thank you so much for asking me, inviting me to be part of this new series on New Frontiers with regard to different neurochemistry and things that we may be looking at in our future. I'm really glad to be here, and we'll be sharing for the next 90 minutes or so, exploring a new potential mechanism of disease for schizophrenia called the trace immune-associated receptor. So buckle up, we have a lot of territory to cover in a very short time. At the end of the hour, we will shift to a live question answer session. So let me first inform you of some of my disclaimers. I do work for Synovian Pharmaceuticals. This is a program intended for healthcare professionals in the treatment of patients with schizophrenia. It's for your scientific knowledge, and it is not a substitute for your professional medical advice and judgment. So if I mention any molecules that are in development, they are experimental with regard to the trace immune-associated receptor, and they're not available for treatment or authorized for use in any country, and they have no indication at this time. So as far as an introduction goes, one of my biggest goals is that you learn about the trace immune-associated receptor, but I have other goals as well that I'd like to accomplish, and they're threefold. One is that the first goal I have is to remember love, and that when we talk about people who walk into your office, there's a whole group behind them that absolutely love them. And every time a person receives a diagnosis of schizophrenia, the whole family receives it too. So I implore, one of the goals is to remember the love that's present for the family, for their wellness, and what they wish for their family as far as accomplishments in life, and to have, all the things that would be about living a good life: work, job, relationships, family, successes. The second thing tonight I'd like to do is really champion partnership. And at the end of the presentation, I'll be sharing some of the work that we've done with people who have lived experience of mental health conditions. I'm a pharmacologist, but I'm also a singer and a musician. And I was in Brazil a few years ago studying singing and percussion. And I met a gentleman who was a professor at the University of Sao Paulo, was having lunch with him, and Dr. Martins and I were talking about what it takes to make a beautiful piece of music. And he said to me that through great cooperation and great communication, great love is present. And when I heard him say that, like these bells went off in my head. And I just thought, well, that's what it takes to make music. But really, that's what it takes to create wellness as a practice. And the way that we communicate, shared decision making, is really about empathy, compassion, trauma-informed care, and that communication cooperation is really what we need to achieve wellness. I really love the saying that DBSA, Depression Bipolar Support Alliance, utilizes. And it says, from I to we is the difference between illness to wellness. And the way that we walk through life, the way that we, it's been us and them, and it's really about we to really achieve the wellness goals that people have. And the third thing I'd like to do tonight is instill hope. One thing is we have a new mechanism of disease and new receptor sites to target for making medications to hopefully help with the syndrome of schizophrenia and psychosis. But, hope to me is a whole different experience. And I didn't have a good relationship with it for a long time. I thought kind of hope was the mini me of confidence. Like when people are confident, say, I hope that things will be right. And I met Jennifer Marshall. She's the person who started This Is My Brave back in 2014. She and I were on a bus. There's 7 buses headed from the National NAMI convention to Capitol Hill. And she said, I'm going to start an organization that people can tell the lived experience and the successes they've had in moving towards hope and wellness. And lo and behold, 2 years ago, she won the Women of the Year award in Washington, D.C. She's been on Oprah magazine. They have shows internationally. And Jen had on her wrist, she had a new tattoo when I saw her at the APA convention a few years ago. She said, "Look, LG, I have a new tattoo," and it said hope. And I was like trying to be the really supportive friend. And I said, "Well, what does that mean to you?" And she said, "Hold on, pain ends." And it stopped me in my tracks. I would love to be the person that helps instill hope. And when DBSA did a survey a couple years ago, they surveyed 6,400 people with depression, both bipolar and unipolar depression. And when there was write-ins on the survey, one of the things that was said is, if I want to lose hope, I just go to my clinician. And I never want that to be our legacy in what we do. So if today can inspire hope, that makes me really happy. And that I believe that we as clinicians can hold the hope for people who can't hold it for themselves. So I hope to inspire today with this discussion on new mechanism of disease. Before we move to science, I'd like to start with some art. And I'd like to start with art seeing the world through the eyes of someone who has lived experience of a diagnosis of schizophrenia. So this artwork is very near and dear to my heart. As you can see, the beauty of this artwork and the landscapes and the vibrancy of colors. And in fact, it's beautiful to look at. And it's the outlook of someone who is young in their career, they're in college, brilliant person. The vibrancy is present in the choices of the artwork that's utilized. And this person was my brother. This is my brother, Greg Bailey. And when he was 24 years old, he's 10 years older, he received a diagnosis of schizophrenia. And one of the things that was so poignant in my experience of him is he had the highest IQ ever tested in our community. He was a real Renaissance man. My dad was a high tower installer, so climbing was part of our family experience. We had a 200-foot tower in our backyard, and there was a rebar that my dad's employees used to rappel up and down, and my brother took that to extreme heights and climbed every mountain in the Teton Range. And that VW van up in the corner was so organized. I spent so much time hanging out with my brother and his friends. They call me little sister. And everywhere in that van, there was a place for these ropes. My brother was always the lead climber. The ropes were so organized and everything had its place. And, it was just quite a life with that experience. My brother also made and sewed all of his equipment, this backpack, all of the climbing equipment. There's no such thing as REI. So these gents, and they sewed everything that they utilized to climb. This was reflected in his artwork. On the left side of your screen, what you see is a still life underneath a table. And my brother won first place, had exhibits at Southern Illinois University at Carbondale, won awards for his interpretations of still life. And what you see is and this was in the early 20s, and you start to see different types of experiences coming in as my brother loomed closer to having the symptomatology associated with schizophrenia. I remember us watching a movie, and he turned off the TV and he said, there's people inside the TV watching us. And so his artwork disintegrated into the experience of the paranoia that was part of his world. And in fact, if you look at some of the artwork that is right around the time of his first break in psychosis, you can see some of the darkness and the complete disintegration of the personality into the fragmentation that we think of as part of the syndrome of schizophrenia. I share this with you because this is what inspired me to be a pharmacologist. The backpack that you see hangs in my office, and it serves as a reminder of why I do what I do. On the wall, I have this saying that perhaps strength doesn't reside in having never been broken, but in the courage required to grow strong in the broken places. And it's why I became a pharmacologist. It's why I've devoted my life to giving voice to the person who has lived experience of mental health conditions, and why I will continue to search for answers. So thank you for joining me tonight. Thank you for being part of the solution that we seek together. So I'm going to share a little bit about the epidemiology of schizophrenia, just to start us off. And most of you are very much aware in your practices about the high prevalence of schizophrenia, the fact that it occurs in about 0.5 to 1% of folks in the world, that there is a lot of co-occurring illnesses, that people with the diagnosis of schizophrenia have a much higher incidence, about 4 times the general population, of substance use disorder. There's a high prevalence of depression and anxiety, and the significant burden of disease being, schizophrenia takes folks out at the diagnosis usually occurs at the prime of life, in late adolescence, early adulthood, and greatly diminishes quality of life for many people, not all. And that there's also significant comorbidities with regard to illness. When we look at premature death, the majority is from cardiovascular disease as well as suicide. And people die who have schizophrenia about anywhere around the average around 15 years earlier than the general population. The costs are great. There's a huge economic burden. And this is 2013 data, the most recent that's available, about $150 billion or more annually. And the costs are in loss of not only direct costs with inpatient, outpatient medication costs, emergency room, long-term care, but also the humanistic cost. And that is, the criminalization of mental health disorders, homelessness, looking at excess indirect costs of caregiver burden and those types of issues. The clinical presentations are ones that we all are very familiar with. It's interesting. I've heard sometimes folks in training talk to patients about the positive and negative symptoms, and they're not good or bad. I always consider of positive symptoms being things added on to the experience of interpretation of information, and negative symptoms being the things that are subtracted from the personality, where in cognitive symptoms as well. Now, I don't know, November 3rd, Schizophrenia and Psychosis Action Alliance held a patient-focused drug development meeting with the FDA. And they also did a survey, much like the DBSA survey, on what people want with regard to development of new treatments. And overall, care partners talked about delusions and a motivation. And the people with lived experience talked about cognitive symptomatology, feeling like they can't actualize their desires in life, that because of the symptomatology keeping them from actualizing motivation and being able to think clearly. And cognitive was a really big piece with regard to drug development and new treatment development. All of you know these experiences of when schizophrenia most commonly occurs. It's a little bit later in women. Estrogen is dopamine blocking, so that's a good thing. But and also we do see quite a number of people who have early onset schizophrenia as young as 13 years of age or even younger. I don't like this slide, I'll tell you that. It's one that we've seen the last 23 years about the stages of illness. And, I'm so happy for the RAISE study that's giving us new hope as far as this residual downward spiral that we used to talk about. So I just want to mention the RAISE study was published in the American Journal of Psychiatry in 2016. And the RAISE study was recover after the initial episode of schizophrenia. And it was a 2-year longitudinal NIMH study that showed that if you have comprehensive, intense interventional care, that you can really change the paradigm of the experience with regard to subsequent decline. And comprehensive care really showed improvement in quality of life, acute improvement in treatment retention, likelihood of utilizing services, and really, outcomes of being able to maintain efficacy in life with regards to work and school, really important pieces. So I'm going to go back to my original slide deck and move on. One of the things that I'm so glad that nowadays we know that the head is connected to the body, that it's not separate. So when we talk about interventions in wellness, it's really about a holistic view of the effects that mental illness and mental health conditions have on people. There was a study in 2017 that showed that in all these different domains, that people with serious mental illness, SMI, including bipolar disorder and schizophrenia, had about 1.5 times the risk compared to the general population for cardiovascular, endocrine issues, digestive, circulatory, and nervous conditions, and that the physical co-occurring illnesses are quite prevalent. There's been research looking in metabolic liabilities as well, that even people who are not on medication have a higher risk of diabetes, about 14%, versus folks in the general population, about 8 to 9%. Schizophrenia is associated with various genetic and neurodevelopmental risk factors. Being a pharmacologist, I get a lot of questions from parents about cannabis. And we know that marijuana is the only modifiable risk factor for the onset of schizophrenia. I always tell people, look, if you have any psychosis in your history, of your family history, stay away from drugs of abuse that can actually exacerbate or bring out symptomatology. There's a high genetic propensity. I know for me, having a sibling that had that was schizophrenia, I have a 10% risk. If it was identical twin, it'd be about 80+% risk. 2 parents, 50% risk. 1 parent, 25% risk. People born in May have a higher incidence of schizophrenia. It's thought that that may be due to viral, the flu. And then there's perinatal, prenatal events that occur. And it's interesting because I recently read a study in the last year that talked about in uterine exposure to events. And the only one that was found to actually decrease brain volume in neonates was in uterine exposure to trauma. So all these types of things, especially in disenfranchised populations, contribute to the liability of mental illness. So schizophrenia is highly heterogeneous. So I will tell you, when we look at the patient, each one has a unique patient phenotypic profile. And that when we look at why schizophrenia occurs, there's over 100 genetic polymorphisms that can contribute to the syndrome of the diagnosis of schizophrenia. So an accurate diagnosis and targeted therapies are very, very important. We have many different opportunities to as we switched from psychiatry being art to a science, we have evidence-based medicine and other types of things that we can fall back on in more targeted therapies. But each person has a unique phenotypic presentation. We have the dopamine hypothesis of schizophrenia, which has been around for many, many years. We know that hyperdopaminergic activity in the striatum contributes to the genesis of psychosis, as well as hypodopaminergic activity in the prefrontal cortex. But the story is evolving. You know, as we look at new mechanisms of disease, even though dopamine is considered kind of the final pathway, the contribution of serotonin modulation, glutamatergic modulation, and gating mechanisms by the gamma-aminobutyric acid system, or GABA, we're starting to have more understanding of how these work and come together to create psychosis. Antagonism of dopamine receptors is still our main mechanism of action and target with regard to antipsychotic treatments. And to date, we discovered that dopamine actually is an issue based on somebody using chlorpromazine in 1954 as an anesthetic. That as an antihistamine contributing in surgical procedures. In 1954, someone used that calming effect of the antihistamine in folks with a diagnosis of schizophrenia, and lo and behold, it had antipsychotic effects. Since 1957, we've had 15 typical antipsychotics released between 57 and 1975. And since that time, we have what's called atypical or second generations. That basically the difference between the first and second is the addition of serotonin as a mechanism of action. So antagonism at the serotonin 5-HT2A receptor. We have dopamine partial agonists as well, aripiprazole, brexpiprazole, and cariprazine. And with all of that potential, we do understand that there are really huge unmet needs. That you know, what we have so far works for positive symptoms, but really the negative symptoms and cognitive symptoms really persist, even with good adherence and good antipsychotic trials. 1/3 of people don't respond to the currently used antipsychotics. We're not sure why that occurs. We're left with treating by choosing medications because most of them work very similarly with regard to the level of efficacy, with the exception of clozapine, which is indicated for treatment-resistant schizophrenia. That we really choose medications based on side effects related to receptor profiling, as well as some of the long-term effects called, as we know, tardive dyskinesia. So because of this incomplete efficacy and intolerable side effects at times, also anosognosia. I don't know if any of you saw in February, there's a great article in People about anosognosia. Eric Smith really talked about his experience. He's a gentleman I actually met a couple of weeks ago. And you know, he's on clozapine, had a complete turnaround for his life, works as a social worker. But, you know, so many people abandon treatment because of lack of efficacy, because of side effects, because of anosognosia, and, you know, the resultant negative sequelae that occurs because of unabated symptomatology. So I find the last bullet point unacceptable, that life expectancy and quality of life are significantly affected in people with schizophrenia, with 80% experiencing disability and a 4.5-fold increased risk of suicide. So that being said, we need different treatments. I'm going to shift now to talking about neural circuits to unmet needs, and also finally talk about the trace immune associated receptor as a therapeutic target in models of psychiatric disorders. We know we've gone beyond the dopamine theory. I mean, dopamine is really, really important, but we also know that the glutamatergic and GABAergic theories, that, NMDA receptor hypofunctioning may contribute to some of the cognitive processing in schizophrenia and negative symptomatology. Glutamate is very important as far as resting membrane potentials in the prefrontal cortex. I kind of look at it like a car. I like cars a lot. So if you have a car on idle, that's kind of like glutamate in the prefrontal cortex. So when you press the foot feed for the gas, the car will go. And in hypoglutamatergic states in the prefrontal cortex, it's less likely that there is spontaneous and rapid thought in the signaling deficits. So we also know that the serotonin 5-HT2A receptor has potential for hypofunction in the cortex, resulting in lowered dopaminergic tone. So this is what we've had the dogma. There's dharma and dogma. So the dogma is in how dopamine for decades, that there's aberrant function in the limbic system. And, when I was taught about dopamine pathways, there was 4 of them. It was the mesolimbic, meso always flowing through, mesolimbic system, the mesocortical system, the tuberoinfundibular system, for which dopamine acts as prolactin inhibitory factor, and then the nigrostriatal, which motor, EPS, extrapyramidal symptoms, motoric side effects are generated based on dopamine blockade. We now know that there is more to the story. Neuroimaging techniques, we've been able to actually go more deeply into the types of imbalances that are seen within the limbic associative striatum and sensory motor cortex. And we know that when these changes, that we can actually measure the estimated mean difference between folks with schizophrenia and controls. What we see is actually the limbic system itself has a lower presynaptic dopamine function than in the associative striatum. And so now we have a new experience with regard to the dopamine disruption and the pathways involved. We have an additional pathway called the associative striatum, or the mesostriatal pathway, that actually the limbic system itself, the mesolimbic system, may contribute to negative symptoms. And as you know, the mesocortical pathway, we've talked about negative symptoms and cognitive symptoms and mood issues. And then, so our targets are a little bit different, and the effect of unabated dopamine blockade can result in worsening of symptomatology. So negative symptoms in the mesocortical, mesolimbic system worsening, the mesostriatal associative striatum blockade actually improving dopaminergic symptoms, but then we get the side effects from dopamine blockade in the other areas. So when these theories come together, we've also included not only the brain theories, but there's body theories with regard to our understanding of the genesis of abnormalities or changes in neurotransmitter tone. So we know that addressing holistically the person with the lived experience of mental conditions is very, very important. We know from things like NBAC tests and the various tests that people with schizophrenia react often to faces differently, to the experiences of, the old adage is a stick or a snake, and the perceptions can be different, and there could be increased reactivity in the HPA axis. We know there's cortisol abnormalities. We know that there's neural inflammation and decreased neurotrophic factors like BDNF, brain dynamic neurotrophic factor, for neuroplasticity. There's excitatory toxicity. You know, it's so important. We've had a lot of commentary in the US about duration of untreated psychosis. In the US, the average is 74 weeks. In Australia, where they have state-funded first break and intervention centers, you know, the duration and a lot of education for high school age folks, the duration of untreated psychosis is 12 weeks. So the longer the brain is bathed in that excitatory experience of psychosis, the harder it is on the neurons itself. We know that adipose tissue, peripheral inflammation, that can contribute to drug non-responsiveness, higher insulin sensitivity issues, and also obesity. Roger McIntyre has done some really good work looking at reversing insulin sensitivity and also obesity with regard to increased drug responsiveness. And then 70% of, we have so much about the gut microbiome, that 70% of serotonin, for instance, comes from the gut, and how important it is for that to be addressed. So we have gone beyond the dopaminergic theory, that we know that blockade of the dopaminergic pathway doesn't address all the imbalances that we see within the brain. And we really need something that's going to adapt and be dynamic over time, and really an allosteric model that can adapt and bring things back into balance, not just block receptors. I love these diagrams. Not everybody agrees with me, but I love them. They're spider plots. And to orient you to the importance of them, you'll see in the very center of the spider plot, there's a 0. And at the very outside perimeter of the spider plot, there's a 4. So the inside of the plot looks at very low receptor affinity. As you move outward, the blue moves outward and towards the perimeter. That's where you have very high receptor affinity. So, and if the circle was a clock face, you'll see from like 12 to 3, there's dopamine receptors. From 3 to 6 are serotonin receptors. We see at 7 and 8 o'clock, alpha 2, 1 and 2. 8:30 is histamine receptors, and muscarinic receptors is from about 9 to 12. Excuse me, hold on a second. So all of the agents to date have as their primary mode of action dopamine affinities with other types of receptors involved. So you can see, for instance, with olanzapine, there's receptor affinity for the D1, D2, 3, primarily D2, but there's also a very high receptor affinity for histamine receptors, which may result in some untoward effects. When we look at some of the newer agents, xanomeline, which is a muscarinic agonist, is currently under development and is being researched for the treatment of schizophrenia. And then we have trace amine associated receptor agonists. There's a couple that are under research right now, Ulodorant being the example. So if you look at the scatter plot on xanomeline, you'll see that it mostly acts on the muscarinic receptors. Ulodorant basically has an effect on the 5-HT1A receptor as an agonist, and is a TAAR1 receptor agonist. So, TAAR receptor, what do we know about it so far? And why is it a target? We've known about the trace amines for a very long time. You may recognize the most popular of the trace amines in psychiatry, tyramine. Monoamine oxidase inhibitors block the breakdown of tyramine. We know the cheese reaction, and people who are on monoamine oxidase inhibitors really need to reduce the amount of tyramine in their diets. Some of the other ones that are common in the human brain include tryptophan, epinephrine, octopamine, phenylethylamine. They come from in nature. They're found in degradation. So some of the other names that were from, proteins degrading in nature include names like cadaverine and putrescine. They are, when I was in school, I was told that traceamines are the sawdust in the brain from the production of monoamine neurotransmitters. You may hear the word called false neurotransmitters versus true neurotransmitters. Monoamine neurotransmitters and traceamines are false neurotransmitters. They're only false because they aren't released in the synapse. They're intracellular in their action for the majority of their lives. Very short half-lives, very small molecules. And the traceamine-associated receptors were discovered in 2001. There's 26 of them. Humans express 6 of them. And they're found in sensory inputs. So we think about schizophrenia as a potential alteration of the senses and the input of the senses. What you'll see is the traceamine-associated receptors that are in the human body are mostly found in the olfactory epithelia, but they are also found in key areas, the TAAR1 in particular, in brain structures associated with psychiatric disorders and mental health conditions. So this includes in the ventral tegmental area, the dorsiraphe nucleus. And what we think that they do is they act as a rheostat or an internal resistor that maintains neurotransmission within defined physiologic limits. So it's a balancer. I was given a lecture the other day, and it was to a bunch of young residents. And I said, well, it's kind of a rheostat mechanism. And what people didn't know what a rheostat was, that it's the old-fashioned control for heat and cooling that you turn. Like if it's too hot, it turns the heat up. And if it's too cold, it turns the heat. No, if it turns opposite, if it's too cold, it turns the heat up. And if it's too hot, it turns the heat down, and it's a rheostat. So the way I think of the traceamine-associated receptor is that it does that quite nicely. And it's found in all of the areas that we associate with various neurotransmitters, GABAergic tone, glutamatergic tone, dopaminergic tone, as well as serotonin. And it's a G protein coupled receptor. And these little squiggles are the 7 protein subunits. And it's expressed in these key areas that have to do with reward pathways, with emotion and motor activity, with regulation of cognition and salience and the propagation and sequencing of thought. So what's different? I keep saying so, I will stop. What's different about the TAAR receptor compared to the receptors that we generally think about is the TAAR receptor is intracellular. And I'm going to show you pictures of that in a minute. So it's found mostly intracellular. It can move around in the cell. It can move to the membrane when necessary. Then it moves back in to the cell. It doesn't have vesicles that it goes into the traceamines. They're very quick acting molecules. These traceamines are both pre and postsynaptic in the synapse, and it often forms heterodimers, meaning that it combines with other G-coupled receptors. In particular, the dopamine receptor the D2, 5-HT1B, alpha 2A, and 5-HT1A are other G protein coupled receptors. So other than in the brain, we talked about the limbic areas, the ventral tegmental area, the substantia nigra, in the dorsal raphe nuclei. It's also in the basal ganglia and prefrontal cortex. In the periphery, fascinating enough, these trace amine-associated receptors are found in the beta cells of the pancreas. They are also prevalent in the stomach and intestines, and also in the leukocytes. I find this very interesting. A couple years ago, there was quite a buzz in the world about complement deposition in folks who have a diagnosis of schizophrenia, that complement deposition in nerves triggers the immune system to prune neurons that are not needed. And this pruning system happens, below the age of 5. There's a big pruning time, but also in late adolescence. And it was shown that people with schizophrenia have a much higher deposition of C4 or complement, and a much greater pruning effect of the neurons therein. We know from a long-standing piece of knowledge we have is that people with schizophrenia have larger ventricular sizes, and that brain volume loss may be part of the neurodegenerative portion of the disease. So I'm not making any comments in particular, but I just found it really fascinating that these are contained in the leukocytes as well. So I talked about, this is a picture representation, and I'm going to spend quite a bit of time on these synapses, trying to explain, how the trace amine-associated receptor works. So this green bundle here is the 7 subunit trace amine-associated receptor. It can move in the cell to the cell membrane, and it forms a coupling or a heterodimerization with the D2 receptor. It interacts and it affects signaling, dopamine signaling, and also inhibitory signaling, both positive and negative, in the pre and postsynaptic neuron. Now, when we talk about specific neurotransmitters, I'm just going to let you know that when the modulation of dopaminergic tone from trace amine-associated receptors is really important. It prevents hyperactivity of the dopaminergic system. I'm going to start with that, and then I'm going to explain it in depth in a few minutes. TAAR1 agonists decrease dopamine in the hyperdopaminergic areas, in the nucleus accumbens, and also in other brain regions. When we talk about its effect on glutamatergic circuits, what we found is that it appears to prevent hypoglutamatergic states in the prefrontal cortex. As I mentioned, you need a resting tone of in the glutamatergic pathways for spontaneous thought to occur and rapid thought and sequencing to occur. So the trace amine-associated receptors appear to prevent the hypoglutamatergic states. And when we talk about serotonin activity, there's a high expression of the trace amine-associated receptor, the TAAR receptor, in the dorsal raphe nuclei. It likely functions endogenously to maintain a balance in serotonin activity. It also increases the potency of 5-HT1A agonist effects and decreases potency with antagonists. So why is 5-HT1A important? 5-HT1A is a postulated receptor that has to do with modulating negative symptomatology as well as verbal memory, executive functioning in patients with schizophrenia. as well as some of the mood disorders. It also serves to oppose extrapyramidal syndromes or motoric side effects associated with dopamine receptor blockade. Before I move into this very intense diagram with regard to what TAAR actually does, I'd like to share a little bit about another graphic about G protein recoupled receptors, because this will help explain what I'm going to say next. So when we have a G protein coupled receptor, this is the GDP, or guanosine diphosphate. When an agonist interacts with TAAR, there's a conformational change that releases the segments of the G protein subunits into the nerve itself. And you see that the beta and gamma subunit translocate to the potassium channel and effectively bind to inwardly rectifying potassium channels. You might wonder, well, what does that mean? Every action potential to move from the resting membrane potential to fire in a nerve has to change from a negative to a positive charge. So by affecting the inwardly rectifying potassium channel, you essentially hyperpolarize the cell so that you calm the cell from action potentials occurring. This alpha subunit goes on to interact with, it's actually physical interaction that interacts with adenylene cyclase and promotes cyclic AMP production, and in turn promotes phosphokinase A and C production. Now, if you're not up on phosphokinase, it's thought to be part of the genesis for control and propagation of mood disorders. I'm going to go back to my original slide. I wanted to explain that because, my first topic is that TAAR1 agonists decrease the firing rate in the midbrain ventral tegmental area dopamine neurons. It does that by this G protein coupled receptor and the subunits helping to hyperpolarize the cell and decrease the firing rate or the propagation of action potentials in the ventral tegmental dopaminergic neurons. And that's how it does it. The second mechanism is that it can presynaptically regulate dopaminergic tone and D2 receptor related autoinhibition. So please shift your gaze to the big circle and presynaptically, and I'll explain this. We look at this interaction when something interacts with the TAAR receptor. We see the dark black line, which means that the TAAR receptor moves from intracellular location to the membrane of the cell, and it couples or heterodimerizes the D2 receptor. That institutes a cascade of events. The bright green line you'll see is pointing at a GI cascade, and this is the G inhibitory pathway. The G inhibitory pathway decreases the action of the AADC, which is aromatic L-amino acid decarboxylase. This AADC does two things. One of them is it's one of the metabolic enzymes that produces trace amines. It also converts DOPA to dopamine. The other pathway that is inhibited by this G inhibitory pathway is TH, or tyrosine hydroxylase. Tyrosine hydroxylase converts tyrosine to DOPA. DOPA is then converted to dopamine by AADC. So when I say that it acts presynaptically to regulate dopaminergic tone, it actually shuts down the production of dopamine itself, as well as the trace amines. It's fascinating. The other piece here, you'll notice there's a red breaking line to the beta-arrestin 2 pathway. Beta-arrestin 2 is a scaffolding protein. It can augment neurotransmission, but it also physically blocks some of the effects of the dopamine interaction and serves to desensitize nerves to the effect of neurotransmission. So by blocking that pathway, you effectively end up keeping the synapse ready to react to whatever's going on. That's my basic understanding of it. The last part of what trace amines actually do is they act postsynaptically to reduce dopamine-driven behaviors. And again, it's the same type of interactions postsynaptically to not only decrease dopaminergic tone and production in this pathway. So, you know, when we look at our original thoughts about why does psychosis occur, that it's an overabundance of dopaminergic tone, we actually can not only change the action potential of the neuron by the G protein, and experiences of the alpha, beta, and gamma subunits, but we actually decrease production of dopamine itself by regulation of the TAAR receptor. So take a breath a minute. That's a lot to digest. Why is this exciting? Because a lot of the preclinical work has shown us that we think that the TAAR1 receptor may be a new target. Part of it, the first thing we've talked about quite a bit so far, is that it's expressed in brain regions that have typically been associated with schizophrenia genesis. So there's polygenetic experiences. It's been shown that people with schizophrenia have higher concentrations in the urine of trace amines. We know that some of the genetic links with regard to the TAAR receptor and mutations that can occur resulting in a higher propensity. If there's 100 genes or more that combine in certain ways to result in the syndrome, but the genetic links kind of lead to potential alterations here. If we use mice that have the trace amine associated receptor taken out, or TAAR1 knockout mice, they show behavioral characteristics that are models that are typical for schizophrenia. So hyperlocomotion, hyperactivity, fear responsiveness, responsible for some of the negative symptomatology that TAAR agonists can help reverse. They modulate dopamine, serotonin, and glutamatergic neurotransmitters. These are all important in schizophrenia. There's a potential role for these trace amine associated receptors in animal models looking at positive, negative, and cognitive symptomatology. We talk about and as well as antidepressant, like for swim tests, some of the socialization tests, time out, socializing with other animals, that these are showing positive responses in these models. There is a poster that was published looking at olanzapine-related weight gain in animals that are fed high-fat diets, that TAAR receptor activation can help reverse weight gain and fat accumulation, as well as choices of food that the animals make that are fed these high and caloric intake. And because of all these types of research, the potential utility for the trace amine associated receptor, the TAAR1 receptor, as a target for disorders, for molecules, for treatment of not only schizophrenia, but there's excitement about potential utilization in mood disorders, substance use disorders with reward pathways, modulation of dopamine reward, metabolic syndromes, and obesity. So it's pretty exciting. The types of things, as I mentioned, Roger McIntyre, I'm not covering this here, but Roger McIntyre's published a recent review as the TAAR receptor's potential in mood disorder treatment. There's been looking at the onset of REM, that it increases REM latency, that it could be potential target for sleep disorders. If we can have something that works for psychosis, but doesn't block dopamine, and you don't have the motoric effects, side effects from a dopamine blockade in the substantia nigra, there's a potential for utilization in Parkinson's disease psychosis. Anything that has high reward pathway stimulation, so substance use disorders and compulsive and binge eating disorders. Excited about potential in glycemic control, as well as metabolic syndrome and management of fasting glucose. That's been shown to be reversed in animal models using trace amine associated receptor agonist. And then who knows about immune responsiveness? But as I mentioned, there's been some really great work looking at immune regulation and brain volume due to pruning, the deposition of complement and pruning within the brain itself during critical periods of time. So in summary, I said it again. So in summary, schizophrenia is a chronic, heterogeneous, and disabling disease. It affects all parts of us. It's a holistic disease. It doesn't spare the body or the brain with regard to influence. All of our current medications really look to block the dopaminergic receptor. We need something that's going to modify dopamine tone and not just block the receptor that it interacts with. The 5-HT2 receptor antagonism has been a step forward with atypical agents, but it's not the whole story. We have great strides looking at choices of medication, looking at risk-benefit profiles, looking at targeted therapies based on our knowledge of pharmacology and our communication with people with lived experience in mental health conditions about what they would like to see as their lives and what they would like as far as patient-focused outcomes. The TAAR1 receptor has the potential as a target for psychiatric disorders, including schizophrenia, and as I mentioned, other dopamine, serotonin, glutamatergic disorders. I'm going to shift a little bit now to my third, or my second, I should say, goal, and that is about champion partnerships. Based on my experience of having family members with a diagnosis of schizophrenia and my passion for elevating their voices with regard to how, not in their, not as symptomatology, decreasing those, but elevating their voice in the process of research and development. About a year and a half ago, I actually became aware of peer support specialists when I worked on the board of directors at DBSA, and I became very much convinced as to their value in helping people navigate their journey to wellness, especially when they're new to diagnosis, when there's mitigating circumstances that result in rehospitalizations and difficulties in engagement in appropriate care. So what I did is for about 3 to 4 months and even longer, I looked for people who were peer support specialists. Peer support specialists, as part of the 21st Century Cures Act, were are part of the healthcare team. The 21st Century Cures Act mandated that. And we know that they make big differences to increasing outcomes, positive outcomes, including reduced hospitalizations and increasing patient engagements and care. They're experts at navigating systems using shared decision-making as a way to integrate both the treatment team and the person with lived experience. And they're an empowering and serve as a living example about how to achieve recovery. So after looking, I actually found 88 people who work on treatment teams. I sent out 185 emails and had lots of phone calls and Zoom meetings with folks who are certified peer support specialists. And we worked together for a year. And we called it the Peer Support Specialist Ambassador Program. And one of the things that we worked on as far as a deliverable was best practices for treatment teams. And we came up with an acronym called Best Support. And this is that the basis for a treatment team is to understand the individual's goals. And this is the basis for the work of the treatment team prior to creation of treatment plans. That education is a really big part of what the treatment team provides, and helping the person to enable them to direct the support they receive. That there are specific roles of the treatment team that are collaborative, and helping the individual know what the roles are and how they can best support the person in deciding the course of action for their treatment. That the individual is the center of the treatment universe. The team consists of the individual, the healthcare practitioner, outside traditional treatment, and others outside traditional treatment roles. And this can include friends, family of choice, religious, spiritual leaders that are chosen by the individual. I know I was at Jesse Brown VA for 10 years, and one of the surveys we did, we expected folks to say, oh, they love us, but the number one person that they liked was the chaplain. So spirituality is very, very important as well. The support is that the individual self-identified needs and goals, that is for which the support is centered. That there is a compassionate understanding of the individual's identity, culture, and trauma. That really compassion and engagement around trauma-informed care is critical. That peer support specialists have been shown to make a big difference in person-focused positive outcomes and are essential part of the treatment team. That CPSS folks act as liaisons. They keep the care person-centered. That clinical team members will listen and value individuals' needs, wants, desires, and discuss options and alternative plans that address the individual's goals. That the team members respect and honor each individual's unique wellness journey, meeting them where they are, and that there's transparency, and that communication is in a format requested by the individual and is accessible. So I'm going to share one more piece, and then we're going to open things up for questions. So give me a second. I am not going to share. Give me a second here. I'm going to stop this real quick. I'm going to stop the share, and I'm going to pull up oh, there it is. Okay, give me 1 minute. And this last share is of someone that I've worked with, Catherine Ponte, and all of these treatment team best practices. She says it better than anyone I know. On 1 second. I'm going to stop the share because I'm not sure if I enabled sound. Here we go. I did. Okay, good. Yeah.
The outcomes are so much better when we're regarded as a person as opposed to an illness.
Battery 100%.
I think it's really important that they take the time to educate you. You know, educated patients are better patients. They're more active if they understand what the treatment is. I think that they should recognize your life goals. Too many times when we become ill, it becomes a before mental illness and an after mental illness, as if nothing that, you know, we wanted, desired before the mental illness counts anymore. And so, you know, we want to be recognized as persons with dreams and hopes that we're suddenly facing challenges. And so I would definitely, you know, advise someone to look for a treatment provider that is interested in your goals and helps you treat you to achieve those goals. Because when we're treated to recovery, we have to be stable. And most healthcare providers treat us to reach stability. That's where their endpoint is, to manage the deficits, manage the relapses, minimize the symptoms. They don't treat us to reach recovery. And being able to pursue those life goals is really a great motivation for us to work as hard as we can to get well. And treatment outcomes are just better. And we're a more, you know, cooperative patient. We listen to our doctors more. We're more compliant. It just, you know, the outcomes are so much better when we're regarded as a person as opposed to an illness. And that's key and primary for me. And shared decision making is absolutely critical to me. And that goes with educating us on different options and choices and letting us make those decisions, because the person with mental illness really has to assume responsibility for that illness. You know, it's something that we do. It's not something that people can do for us or people can make us take to get better. We have to be really motivated to put that work in, because it's a lot of work to get better. And we need to be provided with that environment that nurtures that and encourages that. And I think that's what I really would like to see more patients having, and what would have helped me earlier on in my treatment.
So thank you so much. I realize I'd like to now open things for discussion, and it's for discussion. Catherine Ponte is just a really wonderful person. She has spent 13 years in active psychosis. She's a lawyer. She's on the Yale faculty now, and she established a For Like Minds advocacy organization and does coaching. And I asked her, you know, who comes to you for coaching? She said, you know, LG, it's mostly parents. They don't know what to do. And so she's, if look her up, she's great. She's going to be presenting at Psych Congress this year as well. Questions, comments, thoughts, inspirations?
Yeah, so thank you so much, Dr. Bailey. So as people hopefully drop some questions in the chat, or if you prefer to ask your question live, please feel free to use the raise hand feature in Zoom. We do have one question already. And it's first, again, a thank you for the presentation. And then, are there any known natural agonists or antagonists of TAAR1? And if yes, is their effect significant enough to show a change?
Yes, there are lots of natural agonists. The traceamines are natural agonists at TAAR1. If you've ever enjoyed a fermented meat product, you have had an infusion of traceamines. If you like chocolate, you've had an infusion of traceamines. So there's a lot of natural endogenous traceamines. surprisingly enough, the trace amino-associative receptor, there's 26 of them. The invertebrates, use trace amines as neurotransmitters. The flying fox has all 26, and the bottlenose dolphins have none. So they don't need to really smell in the water. So they function by sound vibration. So kind of interesting.